Hey, good afternoon. We're going to go ahead and get started. Can you hear me?
Yes.
Okay. So we're going to get started with today's town hall. And kind of interesting that today is now week 11 of doing this. So we'll see where we are and we'll see how things have progressed. So the first person I'm going to have briefly talk to us is Dr. Lynn Paxton. And Lynn is somebody who I've known for a long time. She did her undergrad in Princeton and then had her MD from UCSF when she got an MPH from Berkeley, and then was an EIS officer here at CDC. And she went on to Uganda where she worked in the Rakai Project, a big Huh? Sorry about this. Okay, so hopefully people can see this now. So Lynn Paxton is somebody who I've known for a long time. She did her undergrad at Princeton, got her MPH at Berkeley, MPH at Berkeley, and her MD at UCSF. She was an EIS officer, and then went on to Uganda, where she was in the Rakai Project, which is a major HIV prevention study. And she worked here at CDC also in PrEP, and she was in Tanzania, and then worked in Zika at CDC until 2018 when she retired. But we were fortunate that Kathleen Toomey found her got her out of retirement in April of this year. She's joined Fulton County as the medical director for Fulton County Department of Health, and I figured this was a good opportunity for her to just say hi to everybody, to introduce yourself. And so, Lynn, welcome.
Yeah. Hi. Thanks very much for inviting me, Carlos. It's nice to see you again after so many years. One minor correction. I probably made this mistake when I sent it to you. I wasn't the Zika coordinator for all of CDC. I was the Zika coordinator for the Center for Global Health within CDC. But anyway, I am now at the Fulton County Department of Health. It's a great operation, and I'm really excited to be working with a lot of fabulous people, including Dr. David Holland, who's on the line. And I just want to say I'm very pleased with what you all are doing, and I look forward to working with a lot of you in the future.
So I think it's important, Lynn, thank you very much, because nowadays I think COVID really exemplifies a great example where clinical care and public health have to work together. Yeah. And we really need to figure out a way to really connect and work together so we can achieve the things we need to do, because we cannot just be doing clinical without connecting to public health if we're going to be able to stop this pandemic.
Yeah, that's absolutely true. And I don't know what Dr. Holland's plans were when he speaks a little later today. But one initiative that we are working on here at the Department of Health is to gather together all the actors in this COVID field to help us come up with more of an overall plan, because it has become quite evident to us, as Carlos, as you know, from that email exchanges that we had over the past couple of days, that many people are not aware of some of the different initiatives that the Department of Public Health is following, such as the contact tracing initiative and exactly how that is functioning, and some of the newer scheduling initiatives. And also, in addition, we are well aware that there are many people who are acting in this space who are doing great work in testing, who are doing great work in and dealing with the community and all that. And so we're working to bring all of those people together so that we can make sure that everyone is working in concert with each other. And so that's something that you'll probably be having us reach out to you reach out to you very soon about that.
So we're looking forward to meeting you in person soon, Lynn. And thank you very much for joining today.
I got to jump off. Okay.
I know. Take care. Thank you. Okay, so we'll hear more from Dr. Paxton later on. So let me just go and say what has happened since last Friday. We're at 5.2 million cases and over 300,000 deaths. U.S. is at 1.6 million cases and 96,000 deaths. It's interesting. Russia is now the #2 country, and Brazil is #3. So it's interesting how the countries have changed significantly and who's affected by the epidemic. All 50 states are now partially or totally open. On Monday, there was also the Moderna vaccine study the phase 1 study was announced. We heard about the state budget cuts impacting DPH, and we also heard about hospital systems releasing information on the financial impact the pandemic is having on them. So this is on the Moderna vaccine, and you can see this was only a phase 1 study. It got a lot of press, and I think the most important thing it did is it boosted the stock market. So it was good for your retirement accounts, and my retirement account, I don't think has done anything to combat COVID other than just help the stock market get a little boost. However, we have heard about the studies that are coming, the big studies, the phase 3 studies, and there are three phase 3 studies that will be coming, one from Moderna, one from AstraZeneca, and one from J&J. And if you think about each one of these studies recruiting about 30,000 people, we're talking about 100,000 people are going to be recruited in studies within the next several weeks. So we need to really think about this. We are probably going to be doing here at Grady the Moderna vaccine study. So what are the hotspots for the epidemic now? Well, you can see the hotspots are some countries in Africa, some countries in Latin America. So this has changed dramatically since in the few years as this epidemic has gone on. Here in the US, as I said, 1.5 million cases, close to 100,000 deaths now from this disease. And this is what is currently happening in the US. And you can see now that there are 6 states which the cases are increasing. There are 27 states that are stable, and Georgia is one of them, and there are 19 cases where the epidemic is decreasing. We went from being a state that was decreasing to a state where the epidemic is considered stable now. This is the reopening, and this is, as you can see, all the states have reopened, but this is from COVIDx's strategy website, and you can see Georgia is considered sort of in the red, in the yellow zone, and we're yellow now because we have expanded testing significantly. Our cases are, stable to decreasing, but our ICU capacity is still not what it should be. So we're still watching our ICUs carefully. Just to give you these 2 graphs that I thought were interesting, look at the US now, the case is stabilizing. Look how Brazil, how rapidly it's increasing. And you can see against countries that have done well, look at Taiwan, look at New Zealand that essentially have eliminated this problem. I want to mention the Sweden approach, because Sweden essentially did not close the country. That kept the schools open, closed museums, but essentially, there was no major restrictions that they imposed in Sweden. And they counted on this approach called the herd immunity, and see if herd immunity would take care of the problem. And I'm worried because even though President Trump bashed Sweden in this approach, in fact, this is where the country is going into. By opening the country, we are following the Sweden approach, whether we like it or not. And I can tell you that we are not Sweden. We have less people in single person households. We have more obesity. We have more diabetes. And we have less trust in government and a more individualistic approach. In Sweden, everybody's wearing masks, etc. So I do worry that we're following the Sweden path, even though this is not what we would think is best. And to get to herd immunity, it will take a lot. If currently there are about 10 million Americans or maybe less who are infected, we would need to get to about 225 million Americans infected to get to herd immunity. That would mean about close to 500,000 deaths or more from this disease. So obviously, we're not going to be able to get there without significant pain. Having said that, Sweden's approach is not looking good. You can see the cases and mortality compared to Finland or Norway. And again, it's showing a much higher mortality, which is what you expected. So if we follow this approach, our mortality will continue to go up. So I remind people that the decision to open a country, it's really not a scientific one. It's really not a political one. As this article said, it's an ethical one. And I really think we need to think about that, the ethics of what's happening. I just mentioned this because David is going to talk later about nursing homes, but today in the MMWR, there was about controlling outbreaks in nursing homes, and basically talk about the importance of serial PCR testing of not only people that live in the nursing home, but the people that work in the nursing home as a way to rapidly control outbreaks in nursing homes. And public health is doing that here in the state because nursing homes are a major place where we're having outbreaks. So where are we in the state? Again, 400,000 tests conducted, 41,000 cases, and you can see that now our seroprevalence is under 10%. So we're doing a lot more testing. This is where the cases are. The great majority of cases, number-wise, are here around Atlanta, Fulton, DeKalb, Cobb, Gwinnett. But per 100,000 populations, the area around Albany continues to be the most impacted area. This is from the DPH website, And this is the data that has been gotten a lot of criticism, but I just show it because it, it looks like the cases are stabilizing, but certainly not going down. Top affected counties are here, both in deaths, hospitalizations, and number of cases. Jeff Lennox put the slides together for me, and I just want to show them just because, again, it shows the new cases per day. And you can see new cases per day in the state. We're about 700 to 800 cases reported per day. And we're death-wise, we're about 30 to 40. Yesterday was a huge spike of 78 deaths reported in the state. And you can see where we are. So hopefully we'll stay at that level, but that's still a lot of cases and a lot of deaths on a daily basis. So the summary of Georgia's here of cases, deaths, and tests. And last week alone, we did over 100,000 tests. So what does it mean for Georgia? Well, it means that if you can see here, you can see over time in this month where we've been, looks like our cases are stabilizing. But again, I worry about some areas where the cases are starting to go up rapidly and doubling faster than we would like to. I thought this was in the New York Times a very interesting article. It looks at the coalition of infectious disease, COVID, and chronic diseases. Look at obesity, diabetes, high blood pressure, and you can see the counties that are impacted by both. And it's not surprising, it is here in the South where you have the coalition of chronic diseases and COVID, and we could potentially have a lot of higher mortality as a result of that. So where are we in testing? Well, in testing in the state, we're now doing, the goal was to get to 10,000 tests per day. We're doing now 15,000 tests per day. The goal was to get to a less than 10% seroprevalence. We're at 9% seroprevalence. And the goal was to get to 30,000 tests per 1,000 population. We're at 22.9 per 1,000. So we're not quite at 30,000 per 1,000 population. We're pretty close to that. So again, the state really has stepped up testing quite a bit. Now, this has not been without difficulties and without some challenges. And one of the challenges is that Georgia actually inflated the number of tests, but so did Florida, and so quite frankly did the CDC. They started reporting as COVID tests, serological testing, put them serological testing together with the PCR testing, and obviously that inflated the testing, but people picked that up and said, no, that's not right. And why was this? Well, because if you inflate the denominator, you can then bring your seroprevalence down quite a bit. And everybody was trying to get below that 10% seroprevalence. So again, you put the goal post, you put the goal mark, and people try to cheat to get that result, and you need to be careful about that. I am worried that the state budget cuts may impact DPH and may impact the ability to respond to the epidemic, and maybe we can talk about that later with Dr. Paxton, with Dr. Toomey, or with David. Now, a question that I get asked all the time is, does social distancing work? Here are two studies, one study in JAMA this week, showing that social distancing in fact worked. And the drop in seroprevalence that you saw in this study in Washington State was not because of more testing, it was really because social distancing brought the percentage down. So very clearly social distancing worked. What are we seeing here in Georgia? Well, people say, well, did the governor opening things change? Well, maybe a little bit, but not much. People are still staying home. If you could look at restaurant reservations on OpenTable, even after the opening, they went up a little bit, but haven't gone up to where they used to be. And again, I'm really worried about what's going to happen now that the governor wants, and everybody wants to open churches and religious places, because a lot of outbreaks have occurred in churches. But social distancing does work, and you can see here flu. We essentially shut down the flu very rapidly because of social distancing. So for respiratory viruses, staying at home and social distancing is wonderful. It really works very well. Another question that comes up all the time is, how about people with persistent PCRs? Are they contagious? And then there's very nice study from Korea showing very nicely that you can stay positive and you're not infectious. So people that stay positive for a long time are not infectious, and that's something important to know as we're looking at PCR testing. So where are we in Metro Atlanta? Well, you can see the number of positives going down overall and the number of ICU going down, but not as much. Here at Grady, we're at about 41 cases right now. And you can see our numbers. Again, same thing as in the state. The ICUs have stayed pretty flat, maybe going down a little bit, but the number of cases, we peaked at about 71 COVID positive patients. We're now down in the 30s. So really have taken a dip, and that's been good. And that's is shown here in another graph, again, showing over time the number of admissions, and here looking at the ICU situation. So I want to thank the staff here in the office for, again, continue to providing lunches. I hope people appreciate that and are enjoying those. And again, we'll have next time, I'm going to try to see if we can get a little more information as to the number of the issue related to furloughing and cuts and other things that maybe are worth for people to listen to. I'm going to go now and have Dr. Fauci speak to us. So Dr. Fauci is my Yoda, the Yoda to many of us. And well, Tony, thank you very much for joining us today. I really appreciate you taking time from your busy schedule to be with us here at Emory and at Grady and tell us where we are. And thanks again for all you're doing and for guiding the response at the president's level, at the White House level. It is really an honor and for all of us to see you up there, and really makes us feel that we are in right track when we are on your hands. So tell us, where are we in the research response to this epidemic?
Well, Carlos, thank you. I mean, obviously, the people that you deal with are the people who are really in the trenches on the ground, doing the really difficult work of responding from a public health and clinical standpoint. But while that's going on, there are a number of things at various levels of the research agenda, as you call it. And that's really everything from understanding the ever-evolving pathogenesis of this disease. I think the more we get experience with it, the more we realize of the protean and varied manifestations, the duration of symptoms, the post-viral asthenia symptoms that people are getting, the strange, unusual, and still unexplained pathophysiological phenomenon, microthrombi, Kawasaki-type syndromes in children. All of that's part of the research agenda to understand the natural history. The thing that people most relate to is the development of therapeutics and vaccines, interventions that we will have. One of the things that I'm sure, because I know you and your team there have been very much involved with, is the testing of therapeutics, with remdesivir, which I think you all know very well, was only a modest step in the right direction in a select group of individuals who are hospitalized patients with lung disease. That, to me, is as much a proof of concept than it is a drug that is going to really solve many of our problems, because it proves that an antiviral can actually have a positive impact, as modest as it was.
What did I do wrong?
In decreasing the time to recovery. There's another study which I know you all are involved with, which is Act 2, using remdesivir in combination with a drug that blocks inflammatory response. So I think that would be important. And the research agenda goes on. There are a number of other agents that will soon be coming into testing, or even that is already in testing. Other repurposed drugs, convalescent plasma, hyperimmune globulin, monoclonal antibodies. These are all the things that are lining up in different protocols to be able to determine their potential use, both therapeutically as well as from a prophylactic standpoint. And then there's obviously the whole vaccine agenda. Today, which is the 18th, as we're speaking, of May, the data were announced by Moderna Company in one of the several vaccine trials that are out there, namely the phase 1 immunogenicity and safety data on 2 of the doses of the mRNA candidate that actually look good with regard to neutralizing titers. I mean, it's a step in the right direction. As researchers, we've always got to be careful. You can't jump the gun and think you have something that's really a showstopper until you've absolutely proven in multiple ways that you're getting a clinical advantage from it. But those are just some of the things that are going on with research in parallel with the kinds of things that healthcare providers do every day to be able to contain and care appropriately for the outbreak.
Absolutely. And I think, again, also today is a very unique day because we've heard the results of the DSMB from the cabotegravir HPTN 083 study. And as a site that participated in that study, that is incredibly exciting to see. And again, it emphasizes how research really changes practice and really take us to where we need to be, and how research will be, in my mind, research is the exit to get us out of this problem.
Yeah, I mean, that is true. And I have to tell you, to all of your and my colleagues who might be listening to this town hall, as I do spend a lot of time at the White House, in the broader picture as part of the task force, in public health and other measures, the one thing that just keeps coming home to me is that without the science and the research, we wouldn't have the ultimate solution to these issues, because that's what's going to solve this. All of the other things that are being done are absolutely critical. But if you really want to get your arms around it and end it, and really get to the point where it's not something we all have to worry about, it's the science that's going to get us there.
And with that, we'll end. Thank you very much, Tony. Again, appreciate you leading the Institute, and more importantly, to leading the response to this very difficult pandemic. We appreciate all you've done.
Thank you, Carlos, and thank all of your colleagues down there for all the extraordinary things that they're doing. You guys are the real heroes in this. A lot of people don't know who you are individually, but in my mind and in the mind of the country, you're my heroes.
Thank you so much, sir. Appreciate you taking your time.
Take care.
Okay, so with that, we'll end and ask David Holland to give us this update. David?
Okay. So Dr. Paxton talked a little bit about sort of the big picture stuff. We are working with several partners. There's several groups that are doing testing in the metro area, and we're trying to get together on kind of an overall large-scale testing strategy. But underneath that is something that's very important that's being rolled out, is a large trace and contain campaign that is being organized by the Department of Public Health. And they are hiring, I want to say like 1,600 contact tracers. I know that Fulton County is getting 74 to follow up on every single person that's been diagnosed with COVID, make sure that they know their results, know to isolate, and then also do contact tracing around them and ask their contacts to isolate for 14 days. Along with this, there is going to be some resources for things like, food and so forth for people who don't have sick leave and things like that. And this will be in addition to the hotels that have been stood up for individuals who are experiencing homelessness. This is a large campaign that is going on statewide, and it's also supported by some technology. People that are under this program are going to get contacted every day while they're being asked to isolate, to ask about symptoms and so forth. They will have an option to do this electronically, but if they don't sign up for the program on the app that is being rolled out, one of the epidemiologists will actually call them every day either way. So it is a very intensive monitoring program that's going on. And then I think the other thing that you asked me to talk about was the nursing homes. Donald Trump asked for all the nursing homes to be tested, and so the state actually took that on, and the National Guard actually took it upon themselves to test the nursing homes in the state, and I think we're getting about done with that, so there'll be one pass through. We had already tested a number of them in Fulton County, and some of them had been really hard hit. The state has already gone through and called all of the nursing homes in the state, starting with those that had a case identified, to ask them some questions about their implementation of the DPH guidelines. We are taking that a step further. We've got some staff now and also a partnership with Wellstar to do actually some technical assistance inspections of the nursing homes to like go on site and verify that they're doing these things. Wellstar is helping us with the facilities that are in their catchment areas. We're going to be reaching out to some of the other hospitals about some of the other, see if we can get some help. They're providing us with some actual infection prevention experts for this. But we'll be going through the 76 facilities in Fulton County to verify that they're actually following the guidelines and provide them with some assistance if they need it. Cobb County is doing the same thing. So.
Okay, well, thank you, David. I really appreciate it. Thanks a lot. I guess, Dr. Haney, you wanted to say something?
Yeah, thanks, Carlos. So just a quick update from the emergency department. Our volumes have definitely picked up this month. Monday, we're at 340. Tuesday, about 315. We haven't had any days where we've been over 300. We met as a leadership team on Wednesday to talk about our bed allocation for PUIs versus non-PUIs. And we are switching zone 2 from being a hot zone to a cold zone. That'll start on Tuesday morning at 7 a.m. So that'll allow us more space to take care of patients who are non-PUIs, as we're starting to see an increase in that type of patient. The zone 3 and the PES area for now will remain hot areas where we're going to send patients who have a positive, who answer positively to the screening test. We're also, with the help of Susan and Sheena, changing our screening criteria because it was a little bit too broad initially and included things like sore throat and headache. As you can imagine, the number of patients we have to come to the emergency department with a primary complaint of headache is just too much, and we haven't really seen that is particularly good for looking for patients who potentially have COVID. So we're going to change that up as well. The last thing is around testing, and I'm sure Susan, if she's on the phone, will get into this a little bit more. For the last month, Drs. Moore, Wheatley, and Wu and I have sort of been on call 24/7 to try and get a handle on who needs these rapid tests. For those who haven't heard, we're rapidly running out of the rapid tests, and so we're going to stop doing so many of those. We think that from the emergency perspective, for patients we truly need it for patients who might need non-invasive positive pressure ventilation, or who we need to get a rapid test on to avoid admission, we think we need probably 3 to 5 tests a day. I talked to Dr. Todd yesterday, and for the surgical services, the request for rapid tests will need to go through those chiefs of service as well. So more coming on that. I think that there's a meeting planned for early next week to kind of talk about criteria for rapid tests and to see more what that looks like. But that's about it from the emergency department.
Thank you. Appreciate it. Susan?
Thanks.
Can't hear you, Susan.
There, can you hear me now?
Yeah.
Great. Hi, everybody. I wanted to, I guess, follow up with what Dr. Atala was saying. We do want to still encourage that all admissions be tested as a screening test. And if they were not tested by the time they're admitted to your service, or if you're seeing a patient in consult that you can tell has not been tested yet, we want to send a screening test on everyone. So please order those because it's really important to help us understand how much disease there might be that we're not aware of. It'll help us stop the epidemic, to identify people that are infected and don't know it, and help us understand where we need interventions. The OB service has been doing this for a while, as you've heard on our previous town halls, and they've found 6% of their asymptomatic women coming in for labor and delivery have been positive. That's a really significant proportion of asymptomatic people. And if we have if we have as many among our patients admitted that are not sick, that's an important percentage to be missing. Now, it may be that there's something about their population that's higher risk, but we don't know if that would be true. I want to emphasize that masking is critical. Until we have a vaccine and until we have effective treatment, we've got to prevent transmission And wearing a mask is very important. Now, if you are able to stay in a room all by yourself all the time, then you don't need a mask. But that'd be pretty boring. And we have to come out of our rooms to do our work at the hospital. Most of us. I don't know, I get to be on the computer a lot and the phone. But in order to take care of patients and to talk with our colleagues and our, all of our colleagues from all the disciplines, in order to take care of our patients effectively, we've got to talk to each other. And we frequently are in the same room with each other. And if you are in the same room with somebody else, you should have on a mask. I don't care if you're 8 feet apart. If you're in a room inside, you should have on a mask. Especially if you're going to be there for more than 2 minutes. And we sit in rooms for a long time. So please work on having masks and wearing them. And please remind your colleagues. And if you have a hard time doing that, send me a text and I'll remind them for you. I wanted you to know that we haven't bragged about this, and I'm not sure why, but Crestview has done an amazing job. That is our nursing home. It is one of the largest nursing homes, I don't know, anywhere. I think it's the largest nursing home in the state. We have something over 250 beds. And there's been one case of COVID that was admitted to the hospital here and probably didn't have anything to do with that institution. And one patient found on screening at Crestview. And only less than 5 healthcare workers found on screening. They've been very proactive about, they stopped visitors right away. They've been doing universal masking. They stopped their communal, gatherings of any kind at the nursing home. And they have effectively prevented an outbreak or transmission at the nursing home. And that is fabulous. So they're an example for other places and they're going to continue to work very hard at that. If we can do an equally good job at screening our patients and continuing to wear masks universally and cleaning our hands, we can prevent nosocomial transmission of COVID-19 at Grady. And that's a really important thing to prevent. So I'll stop there.
Thank you, Susan. I think really important points, and I want to emphasize the masking. Masking is required, and you need to wear your mask all the time in elevators, when you're doing rounds in rooms, etc. Wayne, you're up.
Okay. Let me see if I can share the screen. All right, so very quick, thanks for getting me again. Basically, this slide shows for the rapid testing. As you can see, we've been through over the past 20 days that we have over 30 tests per day. As we normally, the supply of rapid testings, as we say, between 20 to 30. 30 is our maximum, but we keeping good supply until now. And in the mid-20s is really the cutoff when we truly didn't get much of the kit. Finally, we received some test kit, but then just to let everybody know, the vendor will reduce some capacity for the next 2 weeks because they have to produce other test kit for the reopening of depending on the situation. So furthermore, we know that we'll have to anticipate the shortage of the rapid test kit. And this is a major reason why we cannot offer the stat testing. And I know some clinicians want the Epic building up for the stat testing, and just because of supply issue where it's very difficult for us. And another outcome for this is when we try to get our new generation of high capacity testing, the other vendor also noticed our routine test volume hasn't really catch up because, as you can see, quite a number of tests being shifted to the rapid. So we try to see if everybody's, especially in those need a pre-op when the other things, can order the test earlier as soon as possible. And once you collect the sample, send to the lab quickly so that we can put it on our routine test as quickly as possible. So we don't have to depend on the rapid test as much as Dr. Taylor said. Basically we also have to be on the 24-hour, 7 days a week on call with the ED, with OB, with all the stuff. So we really want to make sure we can meet the demand from the certain patient population. As you can see, just to give you a general number, in the month of April, we have less than 40 rapid testing, but up to now, the 20 days, we get almost 1,000 rapid tests performed. It's already amazing how we managed to do this with 24 hours. But we want everybody know we still need a communication. We still want to limiting, hoping the supply will be back in maybe another after another 2 weeks or so. So that's I'll stop here. Thank you.
Can't hear you.
Okay. Go for it.
Okay. Well, Carlos, thanks very much for having me. For those that don't know me, I'm Mark Rappaport, and I'm the chairman of Psychiatry and Behavioral Sciences. And I'm coming here for 2 reasons. The first and most important reason is I need your help. I need your help to help you. As you know, psychiatry at Grady, as well as psychiatry throughout Emory Healthcare, we have awesome faculty. You know from Nadine, the wonderful work that's being done by caring communities, by so many healthcare professionals. We need your help. We need your help in filling out this survey. It'll take less than 10 minutes. The reason to fill it out is because we need to know what your needs are. We need to know if the major concerns or worries that you have are about childcare. Are they about finances? What are the major concerns you have so that we can communicate to the leaders of our health systems what those concerns are, and so that they can prioritize help for you, as well as all of us that are involved in supplying help for people at Grady and other institutions. To know the type of mental help or stress reduction help or things that we can do for you. So please take a minute, use the link or the QR symbol and fill out this survey. The data will help us to help you. Carlos, did you want me to talk about Zoom fatigue at
Yeah,
all?
talk a little bit about that.
Sure. Last Friday, I was asked to talk about Zoom fatigue. So let me tell you a little bit about it. The awesome thing is there's absolutely no definition of it, and it's not agreed upon. So that's wonderful. So I get to say whatever I want. So Zoom is great in the fact that you can see people and communicate with them, and the fact that, as Carlos does so beautifully, you can share data and share slides with other folks. And Zoom sucks in the sense that it's a monologue. And if you're talking to a whole bunch of people, you can't see their responses. And the other thing that's terrible about Zoom is that it is always changing, and they don't tell you what you're going to change. And so you got to figure out how you share a screen now and who the host is. But there are like 7 easy manifest reasons that people get Zoom fatigue. You know, it's a 2-dimensional interaction instead of a 3-dimensional interaction. You got to learn a whole new set of etiquettes, you know, how you push the buttons to raise your hand or yes or no. It's not what we're used to. Most people take Zoom meetings in the same place all the time. You're stuck in the chair and it becomes exhausting, both the fact that you're looking at the screen and the fact that you're stuck not moving in the same environment all the time. The other challenge we face is that we're using our computers, we're using our mobile devices, our iPads, not just for entertainment and communication, but now we're using it incessantly. This is my research day. This is my 8th Zoom meeting of the day on a day I'm supposed to be doing research. So those are some of the obvious manifest reasons. The latent reasons are are many, but I'm just going to tell you three. We're all going stir crazy. I was going to use a profanity there, but I censored myself. But we're all going stir crazy. And we all have this lack of control. We have a lack of agency about what's going on with COVID, work, wearing masks, whether the person next to you is wearing masks. This lack of agency is a latent reason for some of this Zoom fatigue we have, as well as the fact that there's been this, for people who are distancing at home, there's been this merging of our personal and professional lives. Twice today, one of my dogs was jumping on my lap in the middle of an important Zoom conference. In another one of them, one of the colleagues' 3.5-year-olds all of a sudden ran into the room in a crisis. So there's this merging of our lives where we don't have the physical separation. And there are a lot of more reasons, but what are some of the things you can do about it? Exercise, whether it's dance, whether it's yoga, whether it's running, weightlifting, exercise. Between meetings, stand up, walk, stretch, consciously make a decision to stretch and walk. Change your locations. If you've got a laptop, if you've got a portable device, take meetings, particularly ones where you're not talking, into different locations. It helps. Get out in the sunlight. Get outside, even if it's brief. You can be masked. Hug people. Hugging and physical contact is very important with those whom you can hug while you're socially isolating, because part of the problem we're having is this two-dimensional interaction. Two other things. Laughter helps. Laughter and music helps tremendously. Deep breathing. And then the last one is get retro. Read books, play cards, play chess with a real chessboard, play board games, and really get old-fashioned. Pick up a book with pages and a magazine, because you need that difference in stimulation to keep you less fatigued from Zoom. Carlos gave me only a couple minutes. I took it up. Thank you very much for this opportunity, Carlos.
Thank you, Mark. That was great. Okay, Sarah Johnson, you were going to tell us about dialysis.
Yeah, thanks, Dr. Del Rio, for inviting me. You know, we essentially are running an outpatient dialysis unit at Grady. We have 91 undocumented patients that dialyze throughout the week, 20 to 30 a day, and 90% of those patients are Hispanic. So after essentially our 6th patient got diagnosed positive on May 6th, and we realized he had a cough at that time, that he had been in the dialysis unit just 3 days prior, we talked to Dr. Ray about what we should do about it. And we really appreciate her guidance and Dr. Elam's guidance about taking care of these patients and our staff up on 9D. So we started a screening of all the rest of the patients a few days later. And out of, well, I have 84 in a total now. We had one more tested yesterday. We found 3 asymptomatic positive patients. So in total, we have 9 patients out of our 91 that have tested positive for SARS-CoV. And whether or not they have disease, that's another question. These 6 patients that did get diagnostic tests, because the ones that were admitted also were tested because they were hypoxic in the setting of hypertensive urgency, which is a common presentation for them. So it's hard to know and sort of tease out if they actually had the disease or were tested because they were hypoxic. So moving forward, now that we've found 3 patients positive and asymptomatic, Dr. Ray and Dr. Elam are helping us set up a screening process that may be ongoing to make sure we're staying on top of this vulnerable population, and testing our staff too up on 9D.
Thank you, Sarah. I think this is really a great project and something that I appreciate you having done, because, you know, again, we need to think about the different populations, the different vulnerable populations, and this was one that clearly needed attention, and I appreciate you having done that. Thank you very much. So I'm going to ask now Paulina Rebolledo to tell us about the project that she's been heading around surveillance and for SARS-CoV here. So can you see the slides? Paulina, go ahead.
Yes, can you hear me?
Yeah.
Yeah. So this is thank you, Carlos, for having me. Has been a collaboration to set up a surveillance system within Grady. And this is just, this has been, a work in progress with the Grady Microbiology Lab, Dr. Wang, as well as his staff, and then us from infectious diseases, plus additional people that have helped and have been instrumental in getting the data together. So this is just the first slide. All of you already know which are the platforms that we use at Grady, but again, just wanted to mention the one that we primarily rely on is the Abbott, which is for the majority of the batch samples, and then 2 platforms for rapid testing that, as Dr. Wang mentioned, we have had to scale back in a sense given the shortage in supply of kits. And so this all to say, for the next slide, we have put together some of the data that I've been sending out weekly, which gives information about testing around patients who are under investigation for COVID-19 that are hospitalized. And you can see, similar to what Carlos mentioned for the state, that as testing went up, our overall positivity rate has come down. This again only includes patients that are admitted, that were in the ER, but that had a designation of persons under investigation. So it does not include testing done for screening purposes or for other sort of like placement or other reasons. Next slide. And this is again just sort of like the cumulative cases for for hospitalized individuals with COVID infections starting in March 8th when we had the first patient, and you can see how it has, it's sort of plateaued or maybe leveling off. Next one. And then this is just a quick breakdown of the demographic for, again, hospitalized COVID positive patients, with 58% being male and 41% being female. And you can see the breakdown of the racial backgrounds, with the majority of patients being African American. And then for the amount of patients that we get that are of Hispanic race, it represents a substantial amount compared to this. And then just the overall age distribution of patients, with 75% being older than 50 years old. So, and then this is just for the outpatient testing. This does include, we don't discern between screening and others, but you can see how testing has ramped up in the outpatient setting, with still 11% overall positivity in the last few weeks. And again, just sort of the cumulative representation for the outpatient cases.
Thank you, Paulina, very much. And again, this is going to be part of a bigger, sort of broader database, but I think it's really looking at the spectrum of disease here that we're seeing. And it's a little different than other hospitals, and what the outcomes are and what other things are going to be put together in that database, I think is really good. Annette, can you tell us about what's going on in the ICUs?
Yes, thank you, Carlos. So I don't have much to say about the ICU, which is probably good news. We have about 85 of our 110 beds occupied. We are seeing, we have about 15 PUIs in the ICU and about less than 10 that are actually COVID positive. So I think in the last week or so, we have seen a small decrease in the number of COVID positive patients, and we're starting to see more non-COVID ICU patients being admitted. We're working on, we have colleagues that are working on some protocols, like a self-proning protocol, which will be used in the intermediate care unit and in the intensive care unit. So we're working with the nursing leadership and EPIC teams to get that moving along. Right now it's being physician driven, but hopefully we'll be able to transition and have protocols available for all. And then as we move forward, we are reevaluating sort of the ICU structure and how we're cohorting patients. And we'll always be prepared for a potential surge, especially as we approach the fall. But right now we're trying to reevaluate how we're going to cohort the patients that are truly positive. And that's all I have for now.
Thank you, Annette. Appreciate it. Jeff, can you tell us about the ramping up of non-critical research and what the plans are?
Yes, thank you, Carlos. Before I get started, I'd like to tell or encourage people to take Mark Rappaport's survey, because it was very brief and took less than 10 minutes. So can you show the slides, Carlos? Okay.
Yeah, give me a second.
Okay.
There we go. Here you go. Can you see it now?
Yes. So
okay.
Go back up one slide. So hopefully people are aware that there's 3 phases that the university and the schools have worked out. Phase 1 should have already been mostly completed by the principal investigators that have ongoing research. It includes planning for how to return researchers and research staff and students, et cetera, to resume some limited research activities, planning for opening of facilities, working with department leaders to figure out how we're going to come up with purchasing of PPE and appropriate equipment, social distancing, parking, do we unlock the buildings? I mean, so there's been a lot of planning and discussion going on, and it's supposed to be completed by next week. And in the interim, according to this last bullet, everybody should continue to work from home during this planning phase. Next slide, Carlos. So phase 2 and 3. Phase 2 is a small scale restart starting next week through June 21st, where with approval from the school, investigators can resume bringing in part of their research force or parts of their research, with the goal being that people would probably bring back no more than 40% of their employees or 40% of their research projects at any one time, so that gives us an opportunity to see what kind of problems we have, with social distancing. Do we have to, provide additional space, et cetera? What happens during phase 2 will help during phase 3. And again, during phase 2, people should continue to work remotely if at all possible. And then phase 3, starting June 22nd, would be a broader reopening to research activities. Again, monitoring what experience we're having, looking at social distancing as we become more crowded, and then working from home for those who can. So the reason to do it in these 3 phases is because the safety of the research employees and the participants is paramount, and we want to make sure that we don't have basically an increase in people acquiring COVID while in the workforce. So next slide. So here are some Grady specific activities that I think we can begin now. So if you're a principal investigator and you have a research project that you want to resume, you should look at your space allocation and ensure that those who are going to return, that you have enough space for them, and if not, how you can space things out more. Lunch space, break space. Do you need to have shifts of people? Have one shift come in early, one shift come in late. Start making these plans, discuss them with your chair. The chair will discuss them with the school, and so that when the next phase opens, that you can begin. Assess your PPE needs and supplies. The School of Medicine is looking at how to purchase some of this, but you can also purchase some of it on your own if you so want to. And then where will the subjects be assessed? For Emory on-campus space, they're going to keep the buildings in lockdown until phase 3. And so it's going to be really hard to bring people into Emory University-owned space on the main campus. And even our space here at Grady, we have to make some determinations if we're going to follow the Emory University guidelines, which are currently what the general recommendation is. But for Grady space, I think it's fine to go ahead and talk with the unit or clinic manager where you usually recruit patients or where you might do some assessments, and talk about resuming research subject visits and safety plans once Grady lifts bans on visitors, and I put those in quotes. And I know this is also being addressed at the GCRC level about how to get up and running again for more general research once the visitor ban is lifted or modified, so that we can allow research subjects to enter the building solely for research purposes. So I'm going to go ahead and stop now and put it back to you, Carlos.
Thank you, Jeff. So again, emphasize that this is a critical component of how we get back in business, and how do we get back into research, and how do we really, do it in a safely way. So I really appreciate all the time that you spent doing this, and thank you so much for really putting this together. I just will make sure everybody gets it. So there are a couple of questions in the chat box for Dr. Susan Ray regarding infection control practice. I understand clinicians were retrained when the pandemic began, as colleagues were involved in the retraining of staff. However, on a recent trip to Emory University Med showed that MPs and RNs were not adhering to proper PPE, and are late recovering, thinking that this could be a problem. Do we need to retrain people? How do we do training when new house staff arrives?
Those are big questions. So I guess the person observed at another hospital that people weren't following precautions.
Yeah, I guess so. Yeah.
Okay, because they could have observed that at our hospital too, because it's hard to make everybody, perfect. We have ongoing education for our staff at the hospital, and really that's been necessary because of the changing, especially the almost weekly changing of gowns, the gown supply and what we're using and how we're handling it. We are making plans now for the annual education that occurs every July or every June when we're bringing in new house staff, and also refreshing education for returning house staff. And I do work on that, and I'm making plans for that. Yes, it's a concern. And really, one of my big concerns is just that there is fatigue. Crisis. This was a crisis. We were all excited about it in a reactive way when it started. And now, it's tiring to maintain that level of adrenaline and concern. And while I don't want everybody to have a really high adrenaline that's harmful to us, we do need to continue to be committed to the things that will keep us safe. And hand hygiene has always been really important in healthcare, and it will be critical to limiting the spread of this virus in addition to masking. And one of the, I have to say, this may sound cavalier, but how we put on our gown and take it off, that's really less important. It is. But if you clean your hands before you touch your face, and you clean your hands before you touch the patient, that takes us a long way. And if you wear a mask all the time when you're in a room with somebody else, that takes us a long way also. So those are the things that we'll be emphasizing, because I think they are critical. And if we're perfect at that, a lot of this other stuff is probably not really necessary. So that's what I'm going to keep emphasizing. And we're trying to make it easy. So we've had a problem with our hand hygiene
dispensers.
The dispensers and the stuff that was in the dispensers, the liquid or the gel or whatever. And we have new stuff coming because it was bad. It didn't match. The liquid, the gel was wrong for the dispenser, and it either came out in like none or it just dripped on the floor. It was terrible. That's going to be critical that we have the right, it is critical. I'm feeling terrible that we don't have it widespread yet, but in the next week or two, it should be everywhere. So I'll continue to emphasize those things.
One other question is, what is it, do you think we should limit the number of people who ride in an elevator, even if they're all wearing masks?
I do, and I'm glad you, and Carlos and I have talked about this, and Jeff too, I think. And that's on my to-do list to hopefully get somebody to agree that that's
so today I rode an elevator up to 12, and I realized that instead of 6 feet distance, I had the 6-inch distance.
Yeah.
Right.
Other people on the elevator, and I was just, I was with my face against the wall, so I wouldn't be on anybody's face. I just turned around and I said, maybe everybody needs to be turning around, so we're not breathing at each other. But it was a little scary ride, so I understand this, and I think elevators are a concern.
I wonder if we should close them and make us all walk the stairs again, because that's what we need for our physical health anyway. I don't know anybody who's really be hurt by going up and down the stairs, unless you're really physically unable.
Yeah, and I'd like to encourage people to exclude others from the elevators if they aren't properly wearing their masks. So I told somebody to get off the other day, and they got a little huffy at me, but they weren't wearing their mask and they just got on the elevator. I think we should
Was that
all
a
be.
healthcare worker?
I don't think so. I think it was
Oh.
a family member or something,
see.
but they had a mask, they just weren't wearing it. So I think we need to be elevator police. I don't want to be on an elevator with that person.
I agree with
Well, I'm
you.
going to deputize you, Jeff.
Okay, so somebody's asking, any comments on the CDC announcements yesterday regarding fomites? So I did a lot of research into this because I was frankly really pissed off about that. It wasn't, it's interesting. Jay Butler from CDC said to me, what data, what announcement, what did we say? So it was not what they said, it was the way it was interpreted. And I think what CDC said is that personal transmission is much, much more important than fomite transmission. It doesn't mean that it doesn't exist. But personal transmission, again, talking about what we're saying right now, wearing your mask is much, much, much more important. But I still think
Cleaning
we
your hands.
wash our hands, etc. So the fomite transmission, I think, is not as important as we thought it was, but that doesn't mean that it's not important. So it's difficult message to give, and I think it's hard to say what percentage comes from what. But again, at the end of the day, between being in front of somebody without a mask and picking up the pizza box, I'm more concerned about being in front of somebody without a mask than picking up a pizza box. I mean, I think that's what that's trying to tell us. Question is, do you recommend using eyewear as a general safety measure when interacting with patients who come to consult? I personally think that eyewear is important, and unless we're screening people, I personally think that the easiest thing is, if I'm seeing patients, I wear my mask and I wear my goggles or wear my shield. I think it's just appropriate, and I personally think it's not an overkill. And if you look at the data, there's an interesting article that I'll be happy to share around. If you Google JAMA COVID shields, the Iowa group, Dan Diekema and others wrote this piece in JAMA talking about we ought to use face shields in public instead of wearing masks. They're all in favor of us covering our eyes and our face. So I'm not against it. I cannot say that that's something we all need to do, but I would encourage you to do it. What do you think about face shield or mask, Susan?
Like face shields versus masks?
No, or just wearing them when you're seeing patients.
Oh, well, we do wear them for seeing patients. Face shields are required, or eye coverage is required when you're seeing someone that's suspected of having COVID. And a mask is required all the time. It would be all right to wear a face shield for everybody if you wanted to, but you don't have to. Is that what was
I think
being
that's
asked?
helpful.
Okay.
Okay, another question. Are we tracking the Grady Health employee positives, nurses, MDs, both active PCR and cases? The answer is yes, it's being done. What is the accuracy of the antibody test that Grady's using for staff? It's really good. Grady has the Abbott antibody test, and it's actually probably the best antibody test out there. It's an IgG test that becomes positive about 6 days after people have been infected, 6 to 7 days, but actually has incredible sensitivity and specificity. Of all the antibody tests, it's probably the one commercially available, is probably the one I trust the most.
But it is not the same as the antibody test being done at Emory.
Correct.
And I did have one question that came in. Somebody had the test done both places, and they had different results, which is interesting. And we'll follow up.
So for Susan, we have different platform antibody testing, IgG, IgM, different targets. So if you let me know, I can do more testing.
Ah, fantastic. I'll do this. I was going to send you an email, Wayne, so
Sure.
I'll do that.
Okay.
And there's a question about antibody testing and testing of employees. We're working on making that, and hopefully by next week or the following week, we'll have a mechanism that will allow testing of physicians and residents.
Yeah, it really just involves an issue. It's an issue with scheduling, and there's not.
And putting into Epic and a bunch of other things.
Right. There's the lab is ready. They are ready. It is not the lab. So I want you all to know they're ready. It's all the stuff that happens before that. We're working on it.
Anyway, well, I was going to say thank you very much. Thanks to all the speakers, and thank you, Dr. Rappaport, for joining us. And today is Friday. It's a long weekend, so please enjoy and get do some of the things that Dr. Rappaport suggested. Go out running, enjoy but do it safely. Don't go out with thousands of people, even though the state may be open. We don't want to create cases as a consequence of the Memorial Day weekend. And if nothing happens over the weekend, we'll stay quiet and we'll talk to you later. Thank you very much.